So today we will try to cover dermatology for step 2CK, and we'll start with skin tumors and tumor-like conditions. The first is actinic keratosis. It actually presents as rough plaques in sun-exposed areas, and if because actinic keratosis is a precancerous lesion, we can consider biopsy if these characteristics are present: size more than 1 centimeter, rapid growing lesion with ulcer and tenderness. In these cases, we can consider biopsying it. Otherwise, clinical appearance is enough for diagnosing. Uh, Prognosis is actually, it is a persistent condition. It can progress to squamous cell carcinoma, but most commonly it resolves spontaneously. Treatment is important in isolated lesions. We just go for cryotherapy, and if they are diffuse lesions, then we will go for topical 5-fluorouracil, and we can also use imiquimod and tirbanibulin. I think mostly 5-fluorouracil is the one that is asked. Now the other thing is infantile conditions like hemangioma. This is actually present days to weeks after birth, and this is a proliferative. It proliferates in the first 6 months, and then it involutes in the next 6 months. In the first 6 months, there is rapid this proliferation, and it grows into a bright red plaque, and in the next 6 months it becomes, this is bright red, and then in the next 6 months it becomes deep red or violet, and then it regresses. It is also a clinical diagnosis, but there are some specific diagnostic tests that should be done depending upon the number of hemangioma that we are encountering. If there are more than 5 skin hemangiomas, then we should do a liver USG. If there are facial hemangioma, then we should do a face is near the chest, so think of doing echo and MRI of the head. Now, if it is associated with a beard-like distribution around the face, then we should do laryngoscopy. And if it is associated with lumbosacral, if it is present in lumbosacral areas, then we should do a spinal ultrasound. Management is usually observation, because most of these lesions actually spontaneously resolve, but we can give propranolol for high risk cases like facial lesions which are rapidly growing, ulcerating, and those near the eyes, or if they are present in the subglottic area and causing airway obstruction, or hepatic hemangioma that is leading to high output cardiac failure. In those cases, we can give a medical management in form of beta blocker therapy. Now we have a number of pigmented lesions that can present during childhood. One of the common lesion is cafe lead spots, and they are actually flat and hyperpigmented spots, and they are associated with McCune-Albright syndrome, and also associated with neurofibromatosis. Then the second thing is congenital dermal melanocytosis, which is associated congenital dermal melanosis, where there are blue gray patches, and they are present in Asian population and African Americans. Then we have something called congenital melanocytic nevus, and these are also benign melanocyte proliferation with increased density of hair follicles. So 3 kinds of pigmented lesions: cafe au lait spot, I'm not pronouncing it right, congenital dermal melanocytosis, and congenital melanocytic nevus. Now there is another important skin condition that is also a kind of skin tumor is keratoacanthoma. Keratoacanthoma is a rapid growing nodule with ulceration and keratin plug, and it often, if the prognosis is spontaneous resolution, and it may actually, the DD is squamous cell carcinoma because it may resemble, and sometimes it can progress to squamous cell carcinoma as well, and treatment would be to remove the lesion by surgery. Now, the most important skin malignancy, which is very frequently tested, is malignant melanoma, and we know that there is an A, B, C, D, E criteria, and to be suspicious, more than equal to two of these criteria should be present: asymmetry, border irregularity, color variation, diameter more than 6 mm, and evolving with time. There is also a 7-point checklist where you should have one major or three, more than equal to three minor criterias for diagnosis. And this major criteria is change in size, shape, and color. And the minor criteria are size more than 7 mm, and local inflammation, crusting, and sensory problems. This is not frequently tested, so might skip it as well. And there is something called ugly duckling sign with malignant melanoma. The lesion is, this one particular lesion which is different from the others, so ugly duckling kind of a thing. And there are certain non-melanoma skin cancers as well, and the commonly tested ones are basal cell carcinoma. In basal cell carcinoma, the most important risk factor is the sun, that is UV radiation, and usually fair skinned people are involved, and they will describe the lesion as skin colored pearly nodule with rolled borders, and there will be telangiectatic vessels in the lesion, and sometimes there can be central ulceration with local invasion. Actually, this is a very indolent kind of tumor, does not spread, so local invasion is common. Diagnosis is by biopsy, can be save biopsy, punch biopsy, excisional biopsy. And the treatment is, first line is to remove the tumor by excision with around nearly 4 millimeter margin. And if it is involving sensitive areas like the face, then we can go for Mohs micrographic surgery, in which layer by layer small layers are removed, and each layer is tested for the presence of cancer. And once we reach a layer where there is no more cancer, we can stop resecting. And the second line is actually we can use certain medications like topical 5-fluorouracil and imiquimod, and in low risk tumors we can use curettage and electrodissection as well. So this is about basal cell carcinoma. The other important non melanomatic skin cancer is squamous cell carcinoma. In squamous cell carcinoma, the risk factors are again sun and ultraviolet light. This is the most important risk factor for any kind of skin cancer. Also radiation exposure. And one of the important thing about squamous cell carcinoma is the vignette can give us a chronic non-healing scar, and if a cancer is to develop in a chronic non-healing scar, then that cancer is squamous cell type. Also, it happens in immunosuppressed patients also. uh, Usually it will be an ulcer with scaly plaques. And squamous cell carcinoma in situ is actually a well demarcated plaque. The diagnosis again is same: biopsy, which can be either punch biopsy, save biopsy, or excisional biopsy. And we find dysplastic keratinocytes. uh, the treatment depends upon whether the squamous cell carcinoma is invasive or it is in situ. If it is invasive, we excise with again 4 mm margins, just like basal cell carcinoma. And also we can do Mohs micrographic surgery with invasive ones. And in situ, again, we can excise with 4 mm margins. We can go for curettage and electrodissection. We can go for cryotherapy and topical 5-fluorouracil and imiquimod. So not much different from what we do for the vessel cell carcinoma. In a Mohs micrographic surgery, the visible lesion is first seen and thin layers are removed, and then next layer is removed, and then final layer is removed till the layers are then they are simultaneously checked till we reach a layer which is cancer free. Now let us discuss a few of the dermatologic conditions in infants. The important ones that is tested are seborrheic dermatitis. The seborrheic dermatitis in the scalp, it is also known as cradle cap. It involves the face and areas around the ear, and it presents as yellow and greasy scales. It also can present in the folds of the body, like the neck folds and the axilla, the groin, the diaper area, and the umbilicus. Whenever there is a decreased airflow, so this can be present as confluent erythema in these areas. They will present as glistening confluent erythematous lesions. There is just mild pruritus and there will be no systemic symptoms. And the first line treatment is using non-medicated shampoos to keep the areas clean, and we can use emollients also. And second line, if it is severe and not responding to the first line treatment, we can use second line like topical antifungals, and we can also use low potency corticosteroids in these patients. Uh, Now let us discuss a very important condition called acne vulgaris, which is very commonly tested as well. And acne vulgaris, we will treat the patient. There are actually 3 varieties of presentation. One is comedonal type, the other is inflammatory type, and then the third variety is a most severe one is nodular cystic type. And comedonal type, it is treated with topical retinoids mainly, and the other treatments are benzoic acid and salicylic acid, glycolic acid, like this. In inflammatory type, because now inflammation and infection, we can, and top infection is there, we can use topical antibiotics, and we prefer giving clindamycin and erythromycin in those cases. Topical clindamycin, topical erythromycin. This is used in moderate kind of inflammatory acne. If it is severe inflammatory acne, we might also consider oral antibiotics here. And then we have something called your nodulocystic type, where there are very big nodules, more than 5 mm nodules, and they can appear cystic also, and they merge to form sinus tract and they cause scarring. So this will require another step. So this can again be divided into moderate, severe, and non-responding type. If it is moderate, we start with topical retinoids and benzoyl peroxide and topical antibiotics. And if it is severe, we add oral antibiotics. And if it is non-responding, we add oral isotretinoin. Now, it is very important that before we start oral isotretinoin, we should do serum beta HCG or urine pregnancy test at least twice to rule out pregnancy. And we should use one form of primary contraception and one form of secondary contraception 1 month prior to starting the treatment, and we should continue it 1 month post cessation of treatment, because isotretinoin is highly teratogenic. So this is very important to be considered. And mainly the bacteria that is involved is Cutibacterium acne. And now let us discuss diaper dermatitis, which is again a important topic. Diaper dermatitis can, the disease can involve one condition. The first condition is irritant diaper dermatitis. Then we have something called candida diaper dermatitis, and then we have something called perianal streptococcus infection. Perianal strep. Perianal. Sorry, perianal strep. Now, irritant is actually because of contact. So we can imagine that if when the baby is wearing a diaper, the uh, uh, skin folds will be closed actually. The diaper will not come in contact with the skin folds. So it is very characteristic that irritant diaper dermatitis, it spares the skin folds. So very important is that it spares the skin fold, because this is what differentiate it from the candida. Candida will occur everywhere. It is not because of contact. So it will involve the skin folds. And irritant is the most common type, and candida is the second most common type. This will be a red area with plaques and papules. This will be a beefy red. This will be beefy red confluent plaques, but this thing is not like, if you see the pictures, it's okay. The thing we should remember is sparing the skin fold and involving the skin fold actually. And this can also have satellite lesions associated with it. For irritant dermatitis, the treatment is using a barrier between the skin and the diaper, like using zinc oxide or using petrolatum jelly. And for candida, we are using topical nystatin. And the last kind is perianal strep. It happens in school going, up to school going age it can happen, like from infants to school going age. These kids can have this perianal strep. It is a bright lesion with sharply demarcated areas of erythema. Bright with sharply demarcated areas of erythema in the perianal or perineal area. And here we have to use oral. You have to remember this. We have to use oral amoxicillin. Topical mupirocin and all, they cannot be used here. Oral amoxicillin is the treatment of choice. This is a very important table. Now the next thing is molluscum contagiosum. It mostly happens in children and can happen in adults as well. And in children, usually it happens in the trunk area, the face area, and the axilla. But because this in adults it can be sexually transmitted infection, so it involves the lower abdomen and genitals and lower upper thighs. So all these areas which can be involved in sexual contact. How do we evaluate or evaluate a patient? This is clinical diagnosis. In children, this is just a clinical diagnosis. In adults also the same thing, clinical diagnosis. But once you find molluscum contagiosum in adults, because it's uncommon to have them, we should do other STI testing also, like Neisseria, gonorrhea, Trichomonas vaginalis. And if we have disseminated pox, we should test the patient for HIV. Children, they do not have to be treated, it spontaneously resolves, so just reassurance is what we do. And adults can be treated with cryo, curettage, and topical therapy like podophylotoxin and cantharidin. Now let us discuss common skin infections and start with impetigo. Now impetigo can be non-bullous and it can be bullous. The non-bullous kind is the infective organism can be Staph aureus or group A strep. Bullous is always because of Staph aureus, because of the exfoliative toxin A that it produces. This is important in the pathogenesis of this bullous impetigo. This presents as papules or pustules, And very important that they'll give in the question stems is honey crusted lesions. And bullous impetigo, actually apart from this papules pustules, it will form enlarging and flaccid bullae which have this yellow colored fluid. And once it ruptures it will have this collarate of scales at the periphery, collarate of scales at the periphery of the lesions. We can see a picture of it's very characteristic. And when you have non-bullous impetigo, the treatment is topical. If it is a limited thing, we give topical anti-mupirocin only. And this is very commonly asked. If it is involving just a limited area, we are going to give topical mupirocin, and if it is extensive, we give oral cephalexin. But for bullous impetigo, we don't give any topical antibiotic. It is oral. It is always oral cephalexin. Now, another two important conditions that need to be differentiated are erysipelas and cellulitis. Erysipelas is mainly caused by strep pyogenes, and it only involves the superficial areas of the skin, like it will involve the superficial epidermis. It will involve the epidermis and upper dermis, not the lower dermis. It will involve the epidermis and upper dermis and the lymphatics. It has sharp edges. This is characteristics of erysipelas, and it is rapid spreading, and fever will be present in the early stages of the disease. And it is associated with fever early in the course of the illness. Cellulitis is usually, again, the organism is strep, and it is also associated with methicillin sensitive staph aureus. Cellulitis actually can be non-purulent and purulent. The non-purulent one is caused by strep and MSSA, and purulent one, the organisms are MSSA and MRSA, methicillin sensitive, methicillin resistant staph aureus. Cellulitis will involve deep dermis and subcutaneous tissue, and in the purulent one, along with this involvement, there will be purulent drainage, pus drainage from the cellulitis. And cellulitis is actually, in this erysipelas is rapidly developing, while cellulitis has an indolent slow growing course, and fever presents later in the course of the disease. Another important skin infection caused by staph is Staphylococcus caldate skin syndrome. This is because of the exfoliative toxin again. So exfoliative toxin is responsible for this Staphylococcus caldate skin syndrome as well as purulent cellulitis. The patient will actually be sick. They will present with fever, irritability, and generalized erythema and blisters, and there will be positive Nukolowski sign, that is there will be epidermal shedding. And these patients are to be treated with anti-staphylococcal penicillins like nafcillin and vancomycin, and they also need local wound care. Now, the next important skin infection that has to be discussed is the dermatophytic infections, and that is the tinea infections of the skin. If it involves the body, it's called tinea tinea corporis. If it is involving the intertriginous areas and the groin folds, it is called tinea cruris. And if it is involving the foot, then it is called tinea pedis. And then if it is involving the head, it is called tinea capitis. So there are a few things that put the patient at risk for dermatophytic infection. They are warm and humid climate, and direct contact with an infected person, or fomite or public showers, and contact with kittens. This is also an important risk factor for dermatophytic infection. Patient factors are, if the patient already has a dermatophytic infection, they can auto-inoculate themselves, or occlusive clothing, obesity, And immune deficiency like diabetes, HIV, corticosteroid therapy are also risk factors for dermatophytic infection. So let us first discuss tinea corporis. Tinea corporis is the tinea infection of the body. It happens because of skin to skin contact in humid environment, also contact with rodents. It will be presenting as a scaly red and pruritic patch with centrifugal spread. There will be central clearing. This is described in the vignette, so this description is important. There is central clearing with raised borders, scaly borders actually. The treatment is, first line, if it is a localized infection, would be to give topical antifungals like clotrimazole or terbinafine. And second line, if it's not extensive infection not responding to topical treatment, then we give oral antifungals in form of oral terbinafine and griseofulvin. Then we have tinea pedis. Tinea pedis, again, the most common species that causes it is trichophyton, and it can be uh, acute or chronic. Acute presents with pruritus, pain, erythema, and chronic presents same with pruritus, erythema, but it, because it's chronic, it can have fissures and erosions into the sole and dorsum of the foot also. And for tinea pedis, we use topical antifungal, and we keep the foot dry, and we have to dispose of old footwear actually. And the clinic, for diagnosis, it's usually clinical presentation, but we can use KOH microscopy for the skin testing. And as we already discussed topical antifungals, what are the topical antifungals that we use? We can use topical miconazole, and we can use topical tolnaftate, and topical tolnaftate. And the second line is oral fluconazole. The next is tinea versicolor. This is not a dermatophytic infection but it has tinea in its name, so we'll do it together. Etiology is Malassezia, a fungus called Malassezia furfur or Malassezia globosa. The risk factors, again same, hot and humid climate, and it can present with hypo or hyperpigmented mildly erythematous lesions with or without scaling and pruritus. Diagnosis is KOH prep, which will show a spaghetti with meatball appearance. The spaghetti is the hyphae, and the meatballs are the yeast cells that are present within the hyphae. And treatment is topical fluconazole, selenium sulfide shampoo, and terbinafine. Before we proceed to atopic dermatitis, we actually did not cover tinea capitis. So to summarize, tinea capitis is most common in African American children, and the transmission is by via direct contact or from shared combs. Clinically, they will be scaly erythematous patches with hair loss, and we can have black dots on the affected areas, and they'll also they might give tender occipital lymphadenopathy. So that is, it does not respond to local treatment. We have to treat with oral griseofulvin or oral terbinafine. Now let us come to an important condition called atopic dermatitis. The risk factors are family history of atopy and mutation in filaggrin gene. The clinical features: in acute presentation of atopic dermatitis, there are erythematous red patches associated with pruritus, and in infants they are present on extension surfaces, and in children and adults they are present on fracture surfaces. When this becomes chronic, it presents as lichenified plaques. The treatment is topical emollients, and the first line treatment also involves topical steroids. Second line treatment is topical calcineurin inhibitors like pimecrolimus. There are various complications associated with atopic dermatitis, and mainly involving secondary infections with bacterial and fungal agents. So let's discuss those. So now coming to the infectious complications of atopic dermatitis. The first is impetigo. which can be because of group A streptococcus or Staph aureus. It presents as papules, pustules with honey crusted coating and can be associated with pruritus. Eczema herpeticum, it's caused by HSV1. It is a painful vesicular rash and it causes punched out erosions with hemorrhagic crusting. Now, this is important. This is honey crusting actually, and this is hemorrhagic crusting. And molluscum contagiosum, it is because of pox. This causes skin colored papules with central umbilications, and tinea corporis is caused by trichophytum rubrum. This is again like tinea, a circular patch with central clearing and raised borders. So this is about the complications. The next important topic is contact dermatitis. It again presents in two forms: allergic contact dermatitis, which is a type 4 hypersensitivity reaction, and we have irritant contact dermatitis, which is because of a physical or chemical irritation because of certain exposures. Now, allergic contact dermatitis happens in exposed skin, and irritant is in hands mostly, because hands are the things we use to we used to come in contact with acid, alkali, soap. These are the things that cause this irritant contact dermatitis. The causative agents for allergic contact dermatitis are plants, metals like nickel, rubber, latex, leather, medications. And as we already discussed, for irritants, it's soap, alkali, chemicals, acids. The allergic one presents with as well demarcated red areas, erythematous, papules, pustules, and with chronic lichenification. But irritant one presents with just erythema and fissures. We treat contact dermatitis by avoidance of the suspected allergens, and we can also use topical and systemic corticosteroids. The next condition is dyshydrotic eczema, which is also known as acute palmoplantar eczema. So, as the name suggests, it is acute, recurrent, and palmoplantar. That is, it involves the hands and feet. They are deep-seated pruritic vesicles or bullae, and usually it's a clinical diagnosis. And if we do biopsy, then we'll see spongiosis and lymphocytic predominance infiltrate. The treatment is topical emollients, and we can also use hypotensive corticosteroids topically. The next condition which is commonly tested is hidradenitis suppurativa. What is it? It is actually a keratinocyte proliferation that leads to follicle occlusion, rupture, and inflammation. The risk factors are obesity, diabetes, metabolic syndrome, to be precise, and smoking. Clinical features: unlike your acute palmoplantar eczema, this is not a acute condition. This is rather chronic but recurrent and associated with depression and suicide because of the uh, gross looking lesion that it is. And it involves the intertriginous areas, and the types are mild, moderate, severe. Mild, it is associated with nodules and abscesses and moderate sinus tract and scarring. In severe, there is extensive sinus tracts and scars. And mild, we treat with topical antibiotics like clindamycin. Moderate, we treat with oral antibiotic like tetracyclines. And severe, we treat with TNF alpha inhibitors like adalimumab. And if there are extensive scarring and sinus tract formation, we opt for surgery. This can progress to squamous cell carcinoma of the skin in some cases. The next important topic is autoimmune blistering diseases. There are basically two diseases under this category: pemphigus vulgaris and bullous pemphigoid. These are both autoimmune, so these autoantibodies to pemphigus vulgaris is against desmosomes, and in bullous pemphigoid it is against hemidesmosomes. The age of onset for pemphigus vulgaris is 40 to 60. For bullous pemphigoids, more than 60. Clinical feature mainly pemphigus vulgaris will have pain, and bullous will have pruritus, and bullous actually will have a prodorm of eczematous or urticarial lesions, and after that tense bullae will develop. And in case of pemphigus vulgaris, we have flaccid bullae. Mucosal involvement is present in pemphigus vulgaris while it's not present in bullous, and even Nikolsky sign will be present in pemphigus, absent in bullous. If we do an immunofluorescent test, we'll see the IgG distributed like in a net-like pattern in the intraepidermal area, while the in bullous pemphigoid it is a linear deposition of IgG along the basement membrane. And in histopathological examination, we will see intraepidermal cleavage in pemphigus vulgaris and subepidermal cleavage in case of bullous pemphigoid. Pemphigus vulgaris is treated with in stable cases treated with systemic corticosteroids like prednisolone, and in progressed or advanced cases it is treated with prednisolone plus disease modifying agents like azathioprine, methotrexate and cyclophosphamide, and also we can use mycophenolate mofetil as well. And bullous pemphigoid is treated with topical therapies like high potency corticosteroids, and even systemic therapies like corticosteroids and oral corticosteroids and doxycycline can be used. The next important condition is lichen planus. It is a chronic disease which is associated with something called Koppner phenomenon, where the lesions are formed at the sites of trauma, and it usually spontaneously resolves in 2 years. It is associated with 5 P's: pruritic, purple, polygonal, papules, and plaques. And there is something called Wickham stria also present, which are lacy white network of lines within those polygonal purple plaques, and it can be present in the skin of ankle and wrist, and in the oral mucosa presents at white plaques with mucosal atrophy and ulcers, and can also be present in the genitalia. It is associated with chronic conditions like hepatitis C and certain drugs like ACE inhibitors and thiazides, and we can treat it with topical high potency steroids like betamethasone, and if it is diffuse widespread lesions we can use oral steroids and phototherapy as well. The next condition we'll discuss is porphyria cutanea tada. It is associated with alcohol, estrogen, smoking, hepatitis C and HIV. Clinically presents with blisters, bullae and scarring and calcification like scleroderma. It's very important to remember that it can in the sun exposed areas it presents with it presents in the sun exposed areas. This blisters, bullae, scarring, hyperpigmentation happen in sun exposed areas, and we can diagnose them with increased plasma and urine porphyrins. The next condition is vitiligo. This is also an autoimmune condition where there are depigmented macules on acral areas and extensor surfaces of the body. Face is also commonly involved. It is usually a progressive lesion, but repigmentation has been seen in up to 20% of cases. Because autoimmune diseases go together, it can be associated with other autoimmune conditions like SLE and Addison's disease. If it is a limited depigmentation, limited disease, we can use topical corticosteroids, but if there is extensive involvement, we will use oral corticosteroids, topical calcineurin inhibitors, and something called PUVA therapy. PUVA therapy is Soralen plus UVA light. Next, let us discuss pressure ulcers. They can be stage 1, 2, 3, 4 and unstageable pressure ulcer. Stage 1 is just a localized redness. Stage 2 is a sallow ulcer or blister. Stage 3 is a full thickness ulcer where subcutaneous fat may or may not be visible. Stage 4 is again a full thickness ulcer with exposed bone, tendon and muscles. And stage which is unstageable is a full thickness ulcer which is covered with slough and eschar and has to be removed to be staged. The next topic is scabies. Scabies is what? It is an infection of the skin with mite, Sarcoptes scabies. It spreads via person to person contact, and it's extremely pruritic. Pathognomic burrows are formed in this lesion. And where does it happen? In the interdigital web spaces and genitalia, umbilicus, flexure surfaces of the wrist, extensor surfaces of the elbows, and we treat it with topical 5% permethrin or oral ivermectin. Ivermectin is not preferred in children less than 7 years. The next important highly tested topic is Steven-Johnson syndrome and toxic epidermal necrolysis. When less than 10% of the body surface area is involved, it is SGS, and when more than 30% is involved, it is 10, and between 10 to 30% is an SGS 10 overlap. Usually after exposure to a triggering agent. What are the triggering agents? There are certain common drugs that can trigger these conditions. They can be remembered by a mnemonic A cube NS. A cube is allopurinol, antibiotics like sulfonamides, and anticonvulsants like carbamazepine, phenytoin, and lamotrigine. N stands for NSAIDs, and S stands for sulfasalazine. Other triggers are mycoplasma infections, vaccinations, and graft versus host disease. So, post this infection, from 4 days to 4 weeks post exposure, these conditions can develop. So, as late as 1 month as well. It is usually it begins as an influenza like prodderm, and then like fever, myalgia, fatigue, and then there is rapid development of macules and vesicles, followed by necrosis and sloughing of the epidermis. The mucosa is involved and Nikolsky sign is positive. Patients who are suspected to have SGS or 10, the first thing would be to identify and withdraw the culprit drug, and then we have to transfer the patient to an intensive care or burn unit. Supportive care is given in form of thermoregulation, airway protection, fluid replacement, electrolyte assessment and replacement, nutritional support, pain management, venous thromboembolism prophylaxis, infection control. And medical treatment, we can give systemic immunomodulatory treatment, and the if ocular, oral, and genital mucous membrane is involved, that can be treated. And we should avoid high risk drugs and monitor for secondary cutaneous adverse drug reactions. And then prior to discharge, patients should be informed about the culprit drug, and medical recommendations for treatment and sun protection should be given, and explanation of possible long-term medical complications and medical follow-up and emotional support is necessary. And if needed, we can refer to a support group also, because this is a critical skin illness. The next condition is rosacea. Rosacea is of various categories. The first one is erythematotelangiectatic rosacea. This presents with flushing, erythema, and telangiectasia in the skin region. It can be treated with topical brimonidine and laser pulse light therapy. The second category is papulopustular. As the name suggests, it will present with papules and pustules. The first line is treating for secondary skin infection with topical metronidazole, and second line is oral tetracycline. For ocular rosacea, we use ocular lubricants and topical or systemic antibiotics. And there is one category called phrematous rosacea, which is characterized by irregular thickening of skin, where we give oral isotretinoin, laser therapy, and in refractory cases can be surgery also. The next condition is psoriasis. It presents as well-defined erythematous plaques with silvery scale, and is present on extensor surfaces like knees, elbows, hand, skull, back, and nail plates. It's associated with nail pitting, onycholysis, and psoriatic arthritis, and it is also associated with conditions called seronegative spondyloarthropathy, which is there's a good mnemonic infested called PAIR, psoriatic arthritis, ankylosing spondylitis, IBD, inflammatory bowel disease, and R is for reactive arthritis. The treatment, if it is a topical lesion, we give hypotensive corticosteroids, vitamin D analogs like alipotrine, and calcineurin inhibitors. And for systemic diseases, we use methotrexate, calcineurin inhibitors, and retinoids. The final topic would be hair loss, and the first condition is alopecia areata, which is the autoimmune destruction of the hair bulbs. It presents as painless, patchy, non-scarring hair loss, and there's something called exclamation point here seen in clinical examination, which is narrowing of the hair shafts close to the skin surface. And in hair pull test, more than 5 hair is extracted per pull. And the treatment, if mild to moderate, we can give topical or intralesional corticosteroids, and if it is extensive, we give topical DPCP. DPCP is diphenyl cyclopropinon, and we can give oral corticosteroids as well. The last condition is telogen effluvium. Um, this is actually triggered by serious illnesses, fever, surgery, pregnancy, childbirth, emotional distress, and secondary to endocrine and nutritional disorders. In this condition, there is acute and diffuse non-inflammatory hair loss, but the scalp and hair fibers, they're all normal. It's just the stressful condition that is causing hair loss, and the hair pull test is positive. Because it is related secondary to stressful conditions or certain medical conditions, the management underlie is to treat the underlying cause and reassure the patient that this is a self-limited disorder. And once the patient is cured of the illness, and this hair growth should be back. The final hair loss condition, I'm sorry, what did I do? Okay, the final hair loss condition is male pattern hair loss and female pattern hair loss. This usually it's associated with polygenetic inheritance, and dihydrotestosterone is also involved. In males, there is a frontotemporal loss as well as vertex. In female pattern hair loss, the center of the scalp is where the hair is mostly lost, and also in the vertex. We treat male pattern hair loss with minoxidil and finasteride, and female pattern hair loss with minoxidil. So this completes dermatology for final years and dermatology for clinical years. Thank you.